It's my pleasure today to introduce our endocrinology speaker for Medical Grand Rounds. You know, most of you are well aware of the rapid increase in the number of pharmacological agents we have to treat type 2 diabetes, virtual explosion. You may not be as well aware that we're undergoing a similar dramatic increase in pharmacological agents to treat osteoporosis. And our speaker today, Dr. Felicia Cosman, is going to describe those new drugs and how to use them. Dr. Cosman is a professor of medicine at Columbia. She has been since 2005. In fact, she's been on the faculty since she finished her fellowship in endocrinology there in, I think it was 1998, but you can correct me if I'm wrong on that. She's a product of New York educational system, having gone to college at Cornell, medical school at Stony Brook, and then internship, residency, and fellowship in endocrinology at Columbia. She has been a leader in the field of treatment of osteoporosis and bone health for her entire career. She has published over 175 papers, 50 book chapters, and held many grants for studies and clinical trials in treatment of osteoporosis. So, you know, these are new drugs. Most of us don't have nearly as much experience with them as we have with the antiresorptive agents for treatment of osteoporosis that we've been using for quite some time. And I've always felt that the best way to learn about new drugs is directly from someone who's been intimately involved with the clinical trials to assess the efficacy, safety of those drugs, but also, in Dr. Cosman's case, strategies for how to best combine them with existing therapies, whether in parallel or in series, which is what she's going to talk about today. So we've been trying to get Dr. Cosman to talk here ever since the pandemic started. She was originally scheduled in person, but that was canceled right at the start of the pandemic. But we're very happy to have her here today to tell us about the new anabolic agents for treatment of postmenopausal osteoporosis. Dr. Cosman, welcome.
Well, thanks so much for that introduction, Joe. And it's a pleasure to speak with you virtually today. And these are my disclosures. And I'm going to try to take this view of sequential therapy in kind of a long-term treatment view, and just put it into context that the sequential therapy concept is really appropriate for all of our patients, not just the most severe. And it applies to serial use of different antiresorptive agents, as well as using anabolic agents when appropriate. We know that osteoporosis is chronic and progressive, often diagnosed at the time of menopause, but women are living 40 or 50 years past the average age of menopause at this time, or some are, and our need for a pharmacologic intervention and the choice of medicine has to be based on both risk and age. Medications can and should change as patients age or as disease severity changes, because the risks and benefits differ at different ages. And of course, treatments can be temporarily withdrawn or restarted or intensified to a higher potency medicine when necessary. And our treatment goals differ at different stages of disease. Consistent with this kind of long-term view, American Academy of Clinical Endocrine has recently provided a risk stratification strategy, which I have modified a little bit to separate low and moderate risk patients. But basically, the low risk patients are the ones who've not had any fractures. BMD is above -1, no significant fracture risk probability scores. And most of those patients don't need treatment, of course. The moderate risk patients have had no fracture, but BMD is in the low bone mass category. Frax probabilities are below the treatment range. But some of these patients might benefit from medication to maintain BMD. And that should be consistent with their age. So for example, a 52-year-old healthy woman, no fractures with the T-score shown here, spine T-score minus 2.3, would benefit if she has hot flashes from some form of estrogen therapy. Make her a little older, no hot flashes, maybe give her some breast cancer risk factors, same BMD. The best initial treatment is probably raloxifene. Make her a little bit older, again, same BMD. The best initial treatment is probably a bisphosphonate. So this kind of gets at the concept of individualizing therapy based on age and race. What about the high-risk patients? How are those defined? These are people who've had a single prior fracture, more than, not recently, so a single older prior fracture. They have T-scores in the osteoporosis range, or they have osteopenia with FRAX scores that put them in treatment categories. And for these individuals, we want to improve BMD and reduce fracture risk. Now, for people who meet this criteria, this is a broad category of patients. And for people who meet this high-risk criteria based just on spine BMD, but have had no fracture, treatment is probably the same as I suggested for the moderate risk patient at different ages. You might use estrogens when they're early postmenopausal, raloxifene a little bit later, bisphosphonate a little bit after that. But for women who meet the high-risk category based on more than just the spine, we're thinking about more potent antiresorptive bone-specific therapies. So a 68-year-old woman with no fracture, but hip and spine BMD levels, as shown here, can probably best be treated with a bisphosphonate because there's a high probability that she will attain a non-osteoporotic BMD level with the bisphosphonate over just a 3-year treatment course. But if that same woman has additional risk factors, we would probably set our treatment goals to be higher in terms of BMD than bisphosphonates usually provide. And the best initial treatment might be something like denosumab. A 68-year-old woman, same age, with BMD levels that are lower, you would probably think about starting denosumab because you're more likely to attain non-osteoporotic BMD levels. Given that with bisphosphonates, we don't want to treat for really more than 3 to 5 years at a time, and because we know that you really can't improve BMD very much with patients after 3 years of bisphosphonate therapy. BMD really plateaus, whereas it continues to increase with denosumab. But take that same woman, give her a history of a vertebral fracture 5 years ago, and with that BMD level, anabolic therapy would be optimal. So what about the very high-risk patients now? How do we define these? So the ACE guidelines have been very proactive about defining very high risk. And these are the categories that they have elucidated for us. These include patients who have had fractures on approved osteoporosis medicine, patients who have fractures on medicines known to cause skeletal harm, patients with very low BMD levels, patients at high risk for falls or injurious falls, high fracture probabilities, and also patients who kind of meet this criteria for high imminent risk. And that's been defined by at least the Swiss guidelines and the IOF, International Osteoporosis Foundation, as being greater than or equal to 10% fracture risk in the next 2 years. So who are the people who meet this high imminent risk category? And why am I kind of singling that out? I'm singling out that high risk category because these are the patients in whom we really need to think about osteoporosis treatment more emergently. These are the people who are at such high risk over the next 2 years that we really need to start therapy right away, and we need to start the most potent therapy. So these are the people who are shown here. Most importantly, recent clinical fracture. Overall, when you look at women from a very large database, 65-year-old women who had a first fracture, this was a study done in a US Medicare database, over 377,000 women were followed for up to 5 years. And what they saw was the overall recurrent risk for fracture was 10% in the first year and 18% over the 2 years. So on average, people met criteria for this high imminent risk category. When you break it down by specific site, you see that for clinical spine fractures, the risk over the next year is 14%, very high. And it's different for different fracture types as shown. The ankle fracture has the lowest predictive value, but still, patients who have ankle fractures still have a 5% risk in 1 year, a 10% risk in 2 years, because the first 2 years are pretty equal. It's a linear increase. Thereafter, it starts to decline. So even for ankle fractures, the imminent risk, they meet criteria for this high imminent risk. So all patients with new fractures should be thought of as being at high imminent risk. The reason I have focused on clinical fracture here is because that's the only way that you can actually do this in these big database studies. But we know that radiographic vertebral fractures also are acting the same way. When you look at newly diagnosed radiographically diagnosed vertebral fractures that are asymptomatic, the recurrent vertebral fracture risk is still 20% in 1 year. So newly diagnosed spine fractures and clinical fractures. And then women who have had multiple prior clinical fractures regardless of the timing. So if you've had 2 prior fractures, recurrent risk is 16% over 2 years. If you've had 3 or more, recurrent risk is 25% over 2 years. So these are all the very high risk patients who have high imminent risk of fracture. And then those patients at very high risk based on BMD who have additional risk factors also meet these high imminent risk criteria. And our treatment goals for these patients at very high risk, and particularly those at high imminent risk, is to reduce fracture risk rapidly and potently, and to make sure that those fracture risk reductions are sustained over time. And in order to accomplish this goal, we want to review the data that show that anabolic agents actually look superior than antiresorptives. So these data just review the most potent antiresorptive therapies we have in the Horizon trial using zoledronic acid, and the Freedom trial with Denosumab. And these are the pivotal trials with these 2 agents. We saw rapid vertebral fracture risk reductions with these studies, up to 60 or 70% within the first year. But for non-vertebral fractures, at best you see a 20 to 25% reduction versus placebo, but we don't see any significant decline before 3 years. And in fact, the curves are really just starting to separate at about 18 months. And we've already defined these high imminent risk patients as being at very high risk for fracture early on. So this delayed effect on non-vert fracture is going to allow those patients to have fractures during that really hot period after the first fracture with multiple fractures and so forth. In contrast to the antiresorptives that I just showed, when you look at Teriparatide from the pivotal trial, this is now 20 years old, we saw not only very marked effects against vertebral fracture, but also a 53% reduction against non-vertebral fractures that occurred in really half the time. This is a trial of 19 months median treatment duration, and you're already seeing a 53% risk reduction for non-vert fractures. So about twice the risk reduction versus placebo in about half the time. When you look at a more recent trial, this is the active trial that was the pivotal trial for Abaloparatide. This enrolled in 3 separate arms, a placebo, an Abaloparatide arm, and a Teriparatide arm, which was open label. Nevertheless, it was randomized. And the patients were treated for 18 months. And then they were transitioned to Alendronate as the antiresorptive for an additional 2 years during the extension study. These are the biochemical markers from this trial. And what you see is placebo in the black, of course, and the bone formation marker on the left, the bone resorption marker on the right. And you see that with both teriparatide and abaloparatide, the bone formation markers go up, but so do the bone resorption markers. But the bone resorption markers go up quite a bit more, especially early on with teriparatide compared to abaloparatide. But I wanted to point out that the way that these 2 agents work, they're both interacting with the PTH1 receptor in bone cells. The major effect of these agents is through bone remodeling, so that they stimulate bone remodeling overall, and then formation outstrips resorption in all of these new remodeling cavities that are open. When you look at the fracture data from that study, you see that both abaloparatide and teriparatide were highly effective at reducing new vertebral fractures over 18 months. A very similar degree of effect between the 2 agents, and very, very potent against vertebral fractures. And when you look at the non-vertebral fracture data, you also see with teriparatide a bit of a delay against non-vertebral fracture. I didn't show you the Kaplan-Meier curve for the pivotal trial, but there was a delay there too. But ultimately, a 28% risk reduction, which wasn't quite significant versus placebo. The reason probably for the difference here with regard to teriparatide behavior versus the trial that I showed you first from Near in 2001 is primarily because of the underlying risk of the population being much higher in the other trial versus this one. But nevertheless, abaloparatide did reduce non-vertebral fractures during this 18-month period by 43% compared to placebo, with a rapid separation in the time to first event between placebo and abaloparatide treated patients. And it's important, again, to show that these early strengthening effects, which reduce fractures, are sustained over time. So here you're looking at the overall active results on the left. In the middle, just the extension period. So this is just the time that everybody is on alendronate. And the only difference between the 2 groups is the placebo versus abaloparatide in the first 18 months. And you can see that the effect is maintained during that alendronate phase, and certainly as you look at the entire cumulative experience over the 3.5 years. And this is also true when you look at the non-vertebral fracture occurrence during the extension study, that the risk reduction is sustained over time. And this is key because in order to justify treating with such a more labor-intensive type therapy, you want to show not only the difference in that early 18 to 24-month window, but also the fact, the observation that these fracture risk reductions are sustained during the antiresorptive phase is a key way to rationalize using these therapies. We also see similar data in the FRAME trial, and this is looking at Romosozumab, which was the newest of the anabolic agents approved. And this is the study that was done in moderate risk patients, and the FRAME trial, 7,000 patients randomized to Romosozumab or placebo for 1 year, followed by Denosumab during the second year of the study and during a year of the study extension as well. And I wanted to show the biochemical markers because they illustrate how different this agent is from the two PTH receptor agonist medications. Here you see the bone formation marker on top in yellow, the bone resorption marker in lavender color. And remember, the bone resorption and bone formation markers were both elevated with Teriparatide and Abaloparatide. Here, the bone formation marker is increased, but the bone resorption marker is decreased. And so this agent actually has a dual effect to stimulate formation, but to inhibit resorption. So it's kind of like both an anabolic and an antiresorptive in the same drug. The effects are most marked in the first few months, but you continue to have bone formation above baseline on average at least for 9 months, and there's continued pulsatile increment in the bone formation response to Romosozumab up to 12 months. And then it becomes an antiresorptive drug. So it's really a 1-year opportunity for this medication. And here are the fracture data from the FRAME trial, very early effects at 6 months and a 73% reduction against vertebral fracture during the first year. And when you look at the non-vertebral fracture risks, you see for the full population on the left that there was a risk reduction of 25%, just missed statistical significance. The p-value was 0.096. But in this trial, we did find and this was in a predetermined analysis, that there was a treatment by subgroup interaction by geographic region. And when we pulled out the Latin American population, we saw that the baseline fracture risk there, the placebo group incidence of non-vertebral fracture was very low, 1.2%, much lower than it was predicted to be based on BMD. And there was no treatment effect in that population, that cohort of the trial. But the rest of the world showed a non-vertebral fracture risk in the placebo group that was closer to what was expected, 2.7%. And there was a significant reduction with Romosozumab in that rest of the world population, a 42% risk reduction in just 1 year with a p-value of 0.012. And similarly to what I showed with the Abaloparatide study in active, in the FRAME extension, we see continued or sustained effects against vertebral fracture during the Denosumab treatment part of the study, the antiresorptive phase of the study. And we see the effects against all clinical and non-vertebral fractures sustained as well. These curves do not converge with each other. So when you compare the different anabolics in these pivotal trials versus the best antiresorptive agents, you get the feeling, you make the observation that the effects are more rapid and larger with the anabolic drugs than the antiresorptives. But of course, comparing across the pivotal trials is problematic, and better is to have head-to-head data. And we have 2 trials which are head-to-head. The first is the VERO study, and this compared Teriparatide in blue with Risedronate in red. So whenever you look at these graphs, remind yourself that you're not comparing drug with placebo, you're comparing anabolic to antiresorptive. And you can see already at 1 year, a reduced risk for vertebral fracture, certainly consistent over 2 years in these patients who are all at high risk, all have prevalent vertebral fractures to get into the trial. When you look at the non-vertebral fracture data from this study, on the left, the Kaplan-Meier shows the teriparatide group pulling off of the risedronate group fairly early. The risk reduction just missed statistical significance for non-vertebral fracture with teriparatide. P-value was 0.1, an obvious trend. When you look at non-vertebral fracture number rather than percent of women with non-vertebral fracture, there was a significant reduction with teriparatide compared to risedronate because so many more women had multiple fractures in the risedronate group compared to the teriparatide group. So I think it's still consistent with the observation that teriparatide is far more potent against non-vertebral fracture than is risedronate. And then we have the ARCH trial. And this was a study performed, again, in very high-risk patients. All of them had prevalent vertebral fracture, or 9% of the population had recent hip fracture. Some of those patients had both. The patients were randomized to receive Romosozumab or Alendronate for 1 year, and then everybody transitioned or continued Alendronate for the rest of the trial, which was a median follow-up of just under 3 years because it was an event-driven trial. And the data here also show for Romosozumab in green versus Alendronate in pink, a rapid reduction against vertebral fracture, about a 50% reduction with Romosozumab compared to Alendronate, and also a sustained effect over time. And of course, a reduction of about 19% for non-vertebral fractures with Romosozumab compared to Alendronate, and a 38% reduction with Romosozumab first versus Alendronate first throughout the trial. So clearly indicating the superiority of Romosozumab versus a good antiresorptive drug. So these data helped ACE formulate the recommendation for the very high-risk patients, as shown here, that we should consider anabolic treatments, Abaloparatide, Romosozumab, and Teriparatide, as initial therapy for patients at very high risk of fracture. This is the best approach that will reduce fracture risk rapidly. Now, the second treatment goal that many of us have talked about once we've achieved the fracture risk reduction goal is a BMD normalization, or to get BMD above osteoporosis range. So what's the evidence that BMD on treatment is associated with bone strength? Are we really sure about its ability to predict fracture risk in patients who've received medication? And what's the best treatment sequence to achieve the BMD treatment goals? So we know, of course, in untreated patients that BMD is the single best predictor of fracture risk in people who have not yet had a fracture. And we also know from large extensions of antiresorptive trials for Alendronate therapy from the FLEX trial, and for zoledronic acid from the Horizon extension study. When you look at the BMD level in the hip, this is showing femoral neck BMD, when you look at BMD after treatment with Alendronate for 5 years or zoledronic acid for 3 years, the BMD that you attain at that point is a predictor of the subsequent risk of fracture. This applies to both vertebral and non-vertebral fractures. So if you look here for Alendronate, people who still have a T-score in the osteoporosis range have almost a 30% risk of subsequent fracture over the next 5 years, whereas those who attain a T-score above -2 have 1/3 that risk. Similarly, the patients after 3 years of zoledronic acid who still have osteoporosis have a much higher risk of subsequent fracture than those who do not. The third trial that was a long follow-up in people on antiresorptives is the Freedom Extension study, of course, where we were able to show a BMD in the hip region predicting the risk of subsequent fracture at any time up to 10 years of therapy on denosumab. And you can actually see when the curve starts to flatten out, some point above -2, where you don't seem to get as much bang for the buck as you do between -2 and below. But clearly, for antiresorptive drugs, the evidence is quite clear that the level of BMD that you achieve on these treatments after or while still taking these medications is predictive of subsequent risk of fracture. Now, we also looked at this in the ARCH study. This was, again, the study that combined Romosozumab or Alendronate for a year, followed by Alendronate alone. And in this analysis, we put both of the treatment arms into the model. And you're looking at the relationship between total hip T-score on the x-axis achieved at 1 year as a predictor of subsequent risk of fracture for non-vert fractures on the left, for new or worsening vertebral fracture on the right. You can see that there are very strong relationships between the achieved BMD level and subsequent risk of fracture. And these relationships were independent of treatment and were consistent for all fracture sites. When you look at the spine T-score at 1 year as a predictor of subsequent risk of fracture, you see something quite different for a non-vert fracture. There is no relationship. There is still a relationship for new or worsening vertebral fracture. And so this is really some of the best evidence we have to date to substantiate the thesis that the BMD goal that is most important is the total hip BMD goal, because it is going to allow us to understand what that person's remaining risk of fracture throughout the skeleton is. And secondary to that would be a spine T-score goal. So it's a little bit of a shift in thinking, because we have talked about spine BMD so much over the years. It's much more dynamic than hip BMD, but indeed, hip BMD is probably the most important site to look at, both for prediction of fractures in untreated women, as well as in prediction of fracture risk in people who have been treated. So toward that end, how does a drug like Romosozumab and a treatment sequence beginning with Romosozumab compare with Denosumab alone? So we looked at this in women who were in the FRAME trial, where they received, of course, 1 year of Romosozumab in green, followed by 1 year of Denosumab in blue, compared to the BMD observations over the course of the Freedom Extension study with Denosumab alone. And you see that at 1 year of treatment with Romosozumab, the BMD gain in terms of T-score equates to about 3 years of therapy with Denosumab alone. And the treatment sequence, 2-year treatment sequence of Romo followed by DMAB, equates to about 7 years of treatment with Denosumab alone. So clearly, if you want to try to attain the treatment target above osteoporosis range quickly in these patients at very high risk, you are better off starting with an anabolic drug versus even the most potent antiresorptive. When we look at the opposite treatment sequence, starting with an antiresorptive drug, either bisphosphonates or denosumab, and switching to teriparatide, we see something very different. This is a table from a review that we published a few years ago, where we looked at all these different cohorts of women that had been on bisphosphonates, or in one case, denosumab. And we looked at the change in total hip during teriparatide therapy, which went, most of the time was finished at 18 months, and in one study, or two studies went out to 24 months. But if you scroll down these columns on the right, you see that for each of these cohorts, at 6 months, there's a decline in hip BMD. At 12 months, there's a decline in hip BMD. It starts to turn around for most of the studies. At 18 months, it's really at baseline at least, or a tiny bit above, and then higher at 24 months. But that's very different from the anabolic first treatment approach that I showed you. Now, one of the reasons that I wanted to highlight the difference in mechanism of action between romosozumab and teriparatide is because of this phenomenon, is because treatment sequence beginning with a bisphosphonate and then moving to teriparatide is not ideal for hip BMD. The question is, because of the different mechanism of action, could romosozumab be better than teriparatide? And this structure study was published by Langdell and colleagues a few years ago, specifically looking at women who had been on bisphosphonates for at least 3 years, specifically alendronate for at least 1 year prior to enrollment in the trial. And they were switched to teriparatide or romosozumab. And the main focus of this was hip BMD and hip imaging. First, the spine results show for the teriparatide group in the darker blue an increase of 5.4% on average over the year, compared to the romosozumab group, an increase of 9.8%, just about double the impact on spine BMD. But I'm more focused, and it's more important what happens in the total hip. And here you see for the teriparatide group, the characteristic decline at 6 months and at 12 months for hip BMD. In contrast, in women who were switched from alendronate to romosozumab, an increase in BMD is seen at 6 months and a further increase at 12 months. And this really associates perfectly well with the ultimate effect on hip strength, which is determined by finite element analysis based on the QCT data that were obtained from this same study. So clearly superior benefit with romosozumab versus teriparatide in these patients who were on alendronate initially. When you look at the effect of denosumab and its impact on subsequent use of anabolic agents, the issue is even more significant. Now, these are data taken from the data switch trial published by Leader and colleagues a few years ago, showing the women who were started on teriparatide for 2 years in yellow, followed by denosumab, achieving a nice increase in hip BMD of about 7%, compared to the women who began with denosumab in blue and then switched to teriparatide, where even after 2 full years of teriparatide, the total hip BMD was still below the baseline, the on denosumab baseline at 24 months. And at the end of a 4-year treatment sequence, beginning with teriparatide and then moving to denosumab, the hip BMD increase was more than twice what we see with the 4-year sequence, beginning with denosumab and then switching to teriparatide. So by analogy, how is this switch from denosumab to romosozumab? And we have a little data that were just, this study was just published in JBMR Plus, looking at this particular question. On the left, you're looking at group 1. This is a group of patients that received placebo for 3 years, followed by Romosozumab in green for 1 year, compared to women who received placebo for 2 years, followed by Denosumab for 1 year in blue, and Romosozumab for 1 year in green. The spine's on top and the total hip below. So let's just walk through it. Looking at the spine first, you get a nice increase, of course, in spine BMD in the Romosozumab patients who switch from placebo. You also get a nice increase in those in the Romosozumab treated patients who are treated after Denosumab, but it's 5.3% compared to 9.1% in the patients who switch directly from placebo. But again, the bigger impact is what happens, and the more important impact is what happens on total hip. And on the left is the treatment effect with Romosozumab after placebo, an increase of some 4.6%, whereas the increase in hip BMD upon switch from Denosumab is only 0.9%. So clearly a much less robust increase, but compare that to the decline in hip BMD that we saw for the entire 2 years of Teriparatide therapy after Denosumab. This still is certainly a favorable effect on the hip compared to Teriparatide after Denosumab. We looked at the effect of treatment sequence, putting together the 4 main Romosozumab studies that have been done. You're looking at 1 year gains with Romosozumab on the left from the ARCH and the FRAME trials, where Romosozumab was given as first therapy and the total hip BMD gain was 6 to 6.2%, compared to in the STRUCTURE trial, where the women were given Romosozumab after Alendronate. The BMD gain in the total hip was about half what you saw when Romosozumab was given first, and after Denosumab, the increase is just less than 1% in the small study that I just showed you. And when you look at 2-year sequential gains with Romosozumab followed by Denosumab, the second bar on the right side, the total hip BMD gain averaged 8.5%, whereas the patients who received Denosumab for 1 year followed by Romosozumab for 1 year had a gain which was half of that at 3.8%. So clearly, treatment sequence is very important with Romosozumab, and as it is, of course, with Teriparatide, though you still can get greater benefits if you switch from antiresorptive drugs to Romosozumab versus Teriparatide. We don't have these treatment sequence data comparing Abaloparatide with, as first versus second treatment. Those studies have not been done. I would predict that the response would be a little better than what we see with Teriparatide, but probably not as good as what we see with Romosozumab. Of course, there are always safety considerations for all agents, and these are quite similar for Teriparatide and Abaloparatide. There's, of course, a warning about rodent osteosarcoma. This is not likely a human issue, and there's a new safety study that just explored this after 15 years of follow-up with Teriparatide, and there's no statistical association between human development of osteosarcoma and use of Teriparatide. So that is really something that is still in the label, but has been demoted, is not a box warning, at least for brand name teriparatide any longer. Hypercalcemia and hypercalciuria can occur. Patients can get a little bit orthostatic, particularly at the beginning with these agents, and that can produce some symptoms. With romosozumab, there's evidence of hypersensitivity. Calcium levels can be reduced. This is a monoclonal antibody, and it can produce antibodies to it, but they are not neutralizing antibodies, so you still get the effect of the drug. Most importantly, there was an imbalance in major adverse cardiac events seen in the ARCH study, though this was not seen in the FRAME study when romosozumab was compared with placebo, but we don't want to use romosozumab in patients who might be at very high risk for cardiac events, particularly women with recent events in the last year. So in summary, we are really thinking that osteoporosis treatment has to be individualized and tailored to the patient's age and disease severity, and what you choose at every point as initial therapy should be based on the risk stratification. For the very high-risk patients, anabolic therapy should be considered first, and sequential therapy beginning with anabolic and followed by antiresorptive therapy is most likely to achieve the treatment goals, both to reduce fracture risk rapidly and to achieve a BMD level above osteoporosis range, where the hip site is the key site to consider at least first, and spine secondary. For patients who are on bisphosphonates who need anabolic therapy, we do have data showing that switching to romosozumab will improve hip BMD and strength more than teriparatide. I would say that for patients who are on denosumab who need anabolic therapy, we really need more data before we can make a recommendation, because the study that I showed you specifically looking at this show a poor effect with the switch to teriparatide. That is not something that I would recommend, not a treatment sequence I would recommend, and a modest effect with the switch to romosozumab, and that was only after 1 year of denosumab. So we clearly need more data to evaluate that.